Welcome everybody to Rocket Doctor AI's town hall. Very happy for everybody to be here today. Hopefully we got some new investors as well as some existing investors. We'll be going through the presentation. We'll talk about a few different things and we'll have some time for some questions. If you want to enter, participants can submit questions by clicking on the Q&A button at the bottom of your Zoom screen. A prompt will appear where you can submit your question into the text box and then click send, and hopefully we'll get to it by the end of the presentation. First, just a couple of slides about the disclaimer. And to introduce ourselves, again, some investors here will know us already and some will be new. I'm Dr. Issam Hamza. I'm a family doctor of over 25 years. Been in business and technology even longer than that. And the first company I took public was called CloudMD and grew it from just a handful of small clinics, high-tech clinics that and revenue under 3 million to revenue close to 200 million. And we moved to lists and our market cap went from under 10 million to a high of about 750 million at the peak of COVID. Big proponent of digital health and telemedicine before it became fashionable and mainstream with COVID. And left the company about 4 or 5 years ago, took a bit of time off, and then came to Treatment.com, which was the company before Rocket Doctor AI's rebrand, and became the CEO about 2.5 years ago. Very excited about where we are right now. Very excited about this town hall, being able to talk about what we've done so far and kind of the exciting future. And got to meet Dr. Cherniak a year ago through our partnerships with Google. And it was a perfect fit between our two companies. And we acquired them about a year ago, just over a year ago now. And Bill, if you can introduce yourself as well.
For sure. Hi, everybody. Thanks for joining. Thanks, Isam, for the intro. My name's Bill Cherniak. I'm an emergency doctor trained in family practice, global public health. Again, some folks will know me. And for folks that are new, clinical training across Canada, then went back to school to the US to Hopkins for a public health degree and spent some time at the NIH and working for Kaiser Permanente and across the United States and actually back and forth to East Africa because my first startup was about 15 years ago on the global health nonprofit side. And through that, got involved into high-tech diagnostics through cloud-based teleradiology and had some press in the New York Times that kind of moved me more in the technology sector. And then as an emergency doc, just seeing all the patients coming in that really didn't need to be there, started to think about how we could leverage technology to improve access to care. And we're going to talk to you all about that shortly.
Great. Thanks, Bill. So quickly for the agenda, again, a quick overview of Rocket Doctor, kind of who we are, how we got here, our current solutions, and hopefully some future solutions as well. Kind of our growth and traction, not only in Canada, but now in the US, which is a major focus in our company right now. Our moat, and this is a very important part of it, our moat in terms of our technology and our business plan and the team, our growth opportunity, and then again, the questions and answers at the end. If you want to submit them, hopefully we'll get to them at the end. So first of all, Rocket Doctor AI. We are a company provider-centered for doctors, providing a platform built for scalable care delivery. And the key things here is that we provide something that has trusted AI solutions, care delivery solutions, payer access, and patient demand to help providers deliver better care at scale. And this is a big thing when we talk about inefficiencies in the system, and we'll get to that slide in a second here. So when you are looking at companies like ours or companies in healthcare, and especially in AI and healthcare and software and so on, look at a few things. Look at, can you trust their information? Is it accurate? And I'm sure I just saw on CNN this morning, actually a doctor talking about how she uses ChatGPT to check a few of her own lab results to see about guidance. And because she's educated, she knows what to look for, what's not right, what's right. And she was able to use it effectively, but anybody else really can't because 70% or more sometimes of the time, it may not be accurate or it may not be consistent. It may tell you the right thing once and not another time. It scrapes the internet for whatever information's out there and then presents it in a very confident way as if it's accurate. And you, if you don't have any medical training, might feel like that's the accurate information when it isn't. And for medicine, you pretty much have to be close to 100% accurate or it's not worth it. And especially for physicians, physicians are very critical of something that they can't trust every single time. The other thing is it something that you can actually use, and will you have customers? Meaning that there are great tools out there that maybe are fancy, are shiny, but there's no real business sense to it unless you understand the stakeholders and how things are funded. You may not get paid for it as a company. And so you may create something without a customer. So you have to work backwards from the who's buying this and how are they going to pay for it. And so we provide solutions for the full patient journey. We understand all the stakeholders, the patient, the provider, and the payers. And so we have very powerful proprietary AI powered software for that, and we'll get to it today. Part of our solution is that proprietary software. One of them is the Global Library of Medicine that Treatment.com had that now we're integrating with the Rocket Doctor Sides platform. And we'll get to that slide showing kind of how unique this is and that it's curated AI. It is trusted every single time, like we said before. And it's not what we call generative AI, like the LLMs, where sometimes you might get inaccurate information or it may hallucinate or become racist, as I always say. So it's something you can trust all the time. And we'll get to more information about that because it powers a lot of our solutions. And is it portable? Can you use it for many different solutions out there, like we mentioned before? And I think, and we can talk about security and privacy, and our software can go behind the firewalls of organizations on their platform, on their system, so that they can trust that it's staying within their organization and nothing's leaking out to the internet. It's very interesting always when you talk about privacy and security, when we have people saying it's really, really important, but then they enter all their information into ChatGPT about who's in their family and what diseases they have and what their medical results are and so on. So for us, it's very, very important because healthcare information is probably the number one most valuable information out there. And it's something that we kind of, because we are doctors and we understand the patients, it's something very important to us. And then is it commercially viable? Is it something you can actually make money on? And, we'll talk about some of the things we've done already, like the virtual emergency medicine that's been incredibly powerful and provided incredible efficiency and cost savings. And the commercialization in terms of the revenue it's growing right now from Canada and now in the US. And you'll see that growth in the future slides here. And again, we always talk about built by doctors for doctors. And it's very important to kind of stress that is real. That is something we take to heart. It's actually something that's really important when you start talking to who the customer is, because our customer is the practitioner. And if they think that the person selling them is just a salesperson and not somebody like them who understands all the issues and the stakeholders and all the complications in the healthcare system, it's a hard sell. And so for us, it's a little bit easier. It's kind of one of the first times that we've had kind of buy-in from all the stakeholders because of who we are and where we're coming from the patients to the providers to the payers. They've been all on board with what we're doing, and we're very excited. And again, we'll talk more about the team a little bit later. So why are we here? Like, what are we doing? And again, like I said, I just saw it on CNN and some other. Healthcare is broken. I think in the States, something like $5 trillion is being spent, I think, in healthcare kind of yearly. It's not about more money. It's about the efficient use of the money that's already being spent there. And so it's hard to say always, oh, there's a shortage of doctors. It's not a shortage of doctors. It's that doctors have lives, and when you tell them that they have to sign up for X number of hours and you have to provide 24/7 care for the patient, and 40 to 50% of your time is going to be admin work of doing paperwork and billing and so on, which is something we don't enjoy doing. We want to take care of the patient. Then it's going to cut away from something else. It's going to cut away from either the access to the patients or the patient's access to them, or the time they can spend with patients. And so it's cost the system more money, which ends up where the patients are ending up in emergency, which again, Bill will talk to how much more expensive it is for a patient to show up and emerge versus seeing one of our doctors or another doctor. It's very important. So the soaring cost is going to end. It will end because governments around the world and payers around the world are not going to keep pouring money into it. They're going to look for efficiencies. And we talked about the shrinking access. Something like I think 100 rural hospitals have shut down in the U.S. in the past year. Misinformed care, so misdiagnosis. It's hard for doctors to stay up with every single thing and be able to think about every possible differential diagnosis and potential cause of your symptoms in a 5 or 10 minute visit. But with technology, you can help with that. You can help guide them and make sure that they figure it out. Maybe the fourth thing on a differential diagnosis is something we should look at as well. And so again, it's something again that I think costs the system about $100 billion a year in the US on misdiagnosis. And again, as I mentioned, just too much information for doctors having to monitor tens of thousands of new studies every year is not practical at all. So global library medicine, I mentioned this kind of earlier. This is something we're very proud of. It is something that, that it has taken a lot of care, a lot of time and resources. I believe over 7 or 8 years, over 200 doctors, I think, in our network, spent over 25,000 hours helping curate the information. And uh, because of that, we have the ability now with our platform, with our proprietary algorithm, to diagnose over 1,000 diseases incredibly accurate, and we'll talk about that in a second. We have 17,000 plus symptoms and so on. Every single one, every single piece of information in our platform has a special value, and that value then drives the algorithm to think like a doctor. And this is kind of the key thing. It's not like, hey, you're complaining about a headache. I'm going to ask you these 10 questions. That's not how it works. We've made it so that it mimics the way the doctor approaches medicine. So for instance, before I walk into a room with a patient, I'll look at the chart and I'll look at the past medical history, their current medications, the family history, their latest lab results, and so on. And the risk factors. Are they smoker? How old are they, and so on before I even walk in, because that guides me. So if I walk in to a 20-year-old with chest pain, it's different in terms of what I'm going to think initially than a 70-year-old smoker with chest pain. And so that's very important. The second part is I listen. And so when the patient says, I'm having chest pain, my first question is going to be X. Depending on what the answer is to X, I'm going to shift in real time to the next most important question. And our algorithm does the same thing. It goes to the next most pertinent question. And you'll see this in the demos and hopefully future demos as well, where it's thinking in real time. It's thinking in real time about the most appropriate question, number one. And the number two, what's the next most important question, but also what lab tests they should do next, what imaging they should do. And the differential diagnosis gets updated in real time as well in the background. And why that's important is that not only then, and you'll see this in some of the solutions we have, can we create a really important and valuable history, basically the history taking for the doctor ahead of the appointment. But it can help with the differential diagnosis, but maybe send them for blood work or lab tests or imaging before um, the actual appointment, so that it saves time. Imagine if you did the blood work before your first visit instead of waiting 2 weeks to see the doctor, them sending you for the lab test, waiting for an appointment with the lab to do the lab test, waiting for those results, and then coming back, trying to get another appointment with the doctor to review the results before you get referred to the specialist. Imagine the time savings involved there. And it's not about just the practicality of it or your time is wasted. It actually is really important in medicine. If you catch things early, you avoid complications. And that's really, really important. If you can catch that patient with diabetes or early stroke or early angina and before it becomes a heart attack and so on early, it's really important. Keep them out of hospital, keep them out of complications. And so that's really important. The other thing is that when we say that it's accurate, it's so accurate that medical schools are using it as part of their tools to train and test future medical students on their clinical skills. In medicine, I think something like 80 different countries around the world, there's something called the OSCE exam. And the OSCE exam is a way of testing the students on their clinical skills. And so what happens is there's like 12 rooms. Each room has an actor. Each actor has to act out a disease. And the student has to go in there, ask questions, try to figure out what it is, walk out, write the differential diagnosis, move on to the next room. If they can get maybe 8 out of 12 right or so on, that's not too bad for a student. We actually snuck it into one of these medical exams, these OSCE exams, with a non-medical student, somebody with zero medical training, and told her to run it as if she's a medical student. Nobody knew she wasn't, except for the dean of medicine, and she was able to get 11 out of 12 right on the first diagnosis and the 12th one on the second diagnosis. And so for that fact, University of Minnesota, I believe, used it recently as part of their latest OSCE to help run the OSCE and saving them a lot of money and resources, and because it gave them the ability to test the students and mark it in real time versus historically it took about 3 months to mark these exams. It marked it in real time and gave the preceptors the chance in the background to watch and see the deficiencies in each student and what they need to work on. Because this is a very powerful brain, the global arm of medicine, it can provide many different solutions out there. And we'll talk about some of them, but again, the voice assistants, the medical education is talked about, the pharmacy kiosks, the nurse assistant, and so on. And this is what I'm talking about basically is that our AI products, we did it on purpose to provide that full continuum of care. So everything from the patient intake. So again, I always say imagine you are a young parent on a Sunday night and your kid is sick and you're worried. And what are you going to do? You're going to go to ChatGPT, Google, or Emergency, typically because nothing else is open. But imagine instead that your doctor that you trust, their office has something like this where they have what we call an AI nurse or AI assistant that you can contact 24/7 and start talking to it. It knows your history from your chart and is asking you questions. And based on the interaction, you'll see a video here in a second, an interaction, it'll be able to figure out, number one, whether you need to go emergency or not. So if it's picking up that this could be a stroke or a heart attack in an elderly patient, for instance, it'll send you to emergency. But otherwise, it'll take that information, give it to the doctor ahead of your appointment, book the appointment, let's say, for you. And then when the doctor sees you, it's like having a nurse go in first and take that history, give that differential diagnosis. Maybe you went for the blood work before your visit, and that result is already back already. During the visit, our solutions will have the ability to, as part of the electronic medical record and so on that we have, the ability to use an AI scribe to transcribe the visit so that the doctor's not typing away, they're actually looking at you face to face and have the ability to spend time and resources just with you basically versus trying to make sure they documented every single thing, and also help guide them on some questions they might have forgot to ask or some differential diagnosis they didn't really consider as part of the options there. And then imagine between visits, because again, when you walk out of the room, we're so overwhelmed that, out of mind, out of sight pretty much a lot of times because we have 1,000 or 2,000 patients or whatever. But imagine instead a 24/7 nurse being programmed to check up on you or check up on your kid or see how you're doing after you got out of the hospital, or see how you're doing with your diabetes management and seeing if we need to make another appointment with the doctor and so on. So these are all things that we're implementing, we're integrating, and there's future things as well as we develop that we'll talk about in the future to the investors that we're really excited about. So this is kind of the future of healthcare. It's one of the things I think as patients you should look forward to, better access to care, better care, and so on. So this is exciting. And so finally, from my last slide, before I hand it over to Bill here, I do want to talk about what we've done. So what we've created is, because we understand the stakeholders, we've created a full ecosystem for the doctor. Not only do we have, again, the doctor or the practice and so on is our customer in the middle. What we've created is all these different solutions like ClinBot, where during the visit, it's helping them guide on the questions and diagnosis and lab tests and so on. We have the electronic medical record for them where they're entering all the information. Again, it's our own. We have Bluetooth enabled devices. Bill may talk to it here, where we have the ability for a doctor to see a patient from 2,000 miles away if they're in one of these enabled kiosks where they have a Bluetooth stethoscope or otoscope. We have the ability to triage smartly the patient so that the right patient shows up to see us and the other patients are sent to emergency or go somewhere else. The global library of medicine I mentioned that kind of powers a lot of these things. The AI scribe, where we're talking about not typing away anymore, getting rid of the that whole which, like I said, the headache of typing and not looking at the patient, and making sure that we document everything. And then the AI, the 24/7 AI assistant or nurse as well is really important. We went further though and created a patient marketplace for the doctor as well. So again, Bill will talk about this, where now the provider is empowered. They have the ability now just to see patients, and we even provide sometimes the patients for them already as well, the patient marketplace. And so this is kind of an exciting ecosystem for the provider, because now they're not worried about all the administrative headaches, who to hire, who to fire, leases, contracts, software solutions to use. Are they going to talk to each other? Or are they going to have 10 different windows open? We take care of everything. Billing and accounting and so on is all important. The doctor is now their own boss, which is really important. I'm going to stop on this slide and hand it over to Bill.
Great. Okay. So we'll just play the first demo of one of the products that Isam was chatting about.
How is the chest pain changing over time?
I think it's getting worse.
Do you have chest pain now?
Yes, I do.
Does the pain go into your back?
No. Great. Sorry. Do you mind repeating that in French?
Une crise cardiaque ou infarctus du myocarde survient lorsque le flux sanguin.
Sorry, I forgot. I don't understand French. Can you just tell me what I need to do next? Thank you.
Certainly. Here's what you should do next.
So that again was one of the tools, and it's interesting. You can see obviously it's collecting that information, it's updating the predictive analytics about what the potential diagnosis is, and you can think about from what you've just heard how that could plug into the ecosystem. And then this is a tool called Rocket Doctor Connect. It's something that we've developed through Rocket Doctor Inc. over the years with myself and a group of physicians across the platform. And this is what the general intake looks like. So a patient comes in to request an appointment, and you can see it's asking for, do you have like an Apple Watch, pulse oximeter, other devices at home for actual vital sign readings. So that person put in an oxygen level. You might have noticed that level is a little low at 91%. So then it goes into RD Connect and into these clinical guidelines that are built in an LM to communicate with the patient. And it's asking a series of structured questions. So it's identified you're coming in for shortness of breath. Do you have any chest pain? It sees, oh, the level's a bit low. Wants to know, does the patient have a pre-existing condition? Is this level, normal for what you're used to? Okay, great. You're appropriate for virtual care appointment, which is the whole point. And then it summarizes all of that and populates it into the actual medical record for the physician. And this is what our EMR looks like that we'll chat about in a minute as well. But as you can see, kind of provides that whole basis of, are you right for virtual care to begin with? And then assisting the physician and actually conducting that visit afterwards. And this is ongoing in a clinical trial as we speak, actually, which is very exciting. So just to talk about Rocket Doctor Inc. a little bit more at a high level, which, as Isam noted, was acquired in the spring of last year and now a part of RDAI. There's lots of telehealth companies that are across the world in North America, and many of them people equate with a virtual walk-in clinic, virtual urgent cares, and there's even some discussion of late about commoditization of virtual care, where people are comparing doctors to a coffee bean or a steel alloy and kind of this race to the bottom. But we look at it very differently, which is that we empower physicians in a Shopify-like model to create our own independent practices, largely virtually, but actually in some hybridized in-person and virtual models of care. As you saw, we build all the AI-powered systems, including a proprietary EMR that the physicians practice on. We've created a digital health marketplace. We then put all those physicians out to folks largely in rural and remote communities across Canada, and on government-funded health insurance in the United States to increase access to care ultimately. And, we're going to talk about all the stuff at the bottom with all those logos and a little bit about the growth we've seen across the United States to get to 21 million covered lives. So I always just ask folks when you have a look at this slide to just take a look at the picture on the right side of the screen and just think about all the times that perhaps you've sat in a room that looks a lot like that and waited perhaps just a little bit longer than you would have liked to see a physician. And then imagine that you're one of the approximately 100 million Americans that doesn't have a primary care provider, or 80 million that are on Medicaid. So health insurance for folks at or below the poverty line, pregnant women, children. And then imagine how much more frequently you'd end up waiting in one of those rooms, often unnecessarily. And same applies to the over 6 million Canadians approximately who don't have a family doctor. And then you just have to look at that bottom stat for the amount of time it can take in some cases for somebody to see a physician, particularly if you're in a rural or smaller community. So massive problem, tens of billions of dollars a year, compounding. And then again, you think about what are we able to offer to these physicians to become independent, to create our own practices. And these are just some of the different things that we're providing in addition to all the stuff you heard. But, it's not just, again, a walk-in clinic. We can order labs, imaging, make specialist referrals, book follow-up appointments, and really provide that comprehensive care, even in a virtual ecosystem. But now you're surrounded by hundreds of your colleagues that are working with you to help provide care to patients. And that's really, a direct to consumer approach in many ways. But of interest is we also have many B2B partnerships. And so these are just a few of the highlights for examples. And many of these we've announced actually just in the last 12 months. The County of Lethbridge in Alberta. Central California Alliance for Health is a 500,000 member managed care plan of Medicaid. Obviously in California, in the Central Valley, Melanoma Canada is a nonprofit, and then Georgian Bay General in southwestern Ontario, where we've helped to set up a virtually enabled emergency department. Basically we're taking all of these physicians that are on the marketplace and then leveraging that to partner with these groups to increase access to care in that way. So I think folks on this call will be interested in our approach south of the border in the United States and across the country there. And so, as you think about it, this slide just basically, as the title says, it's hard to do healthcare business across America, and it takes years of preparatory work, particularly if you're trying to provide care to patients that are on government-funded health insurance, so Medicaid and Medicare. And that second step of securing payers, as folks may be aware, many companies are never able to do that in the first place. You can't actually just go out and give them your physician information and expect them to contract with you to be in network. You got to pitch them, you got to win your contracts, and then grow the network. And so, we've been able to successfully do this over the course of the last 2.5 to 3 years, and getting to the position that we got to towards the end of December. And then we'll talk about what's happened since then. So this is just outlining and highlighting for folks as reminders. We put out a bunch of press releases over the last 12 months about all these new in-network contracts that we've won across the United States. And we've got some pretty precise numbers there, but estimates about what's in-network across the 3 states that we're currently operating in. And these are just some examples of releases, and you can find them, of course, online as well. And so, as you think about at a high level for the business, where do we make our money? This was just updated with our Q1 financials that were just announced actually on yesterday morning, I believe. And so, we talked about the direct to consumer approach, and this is averaged out. We in Canada take a percent of all billings, and we can do that because doctors are again practicing within our platform, and we organize so that physicians can bill to the provincial health insurance. And then we basically just charge them a percent of what that billing is at end of month in a reconciliation. And then across the United States, we charge a flat rate per visit, essentially, irrespective of the payer. And then in the middle are those partnerships that you heard about. We also partner with independently owned pharmacies. And so these are kind of set agreements that we have, and that drives some of that partnerships approach. And every physician pays us some form of monthly fee on the platform as more of a typical SaaS EMR fee. And just important to note, again, the Q1 financial details are at the bottom in terms of what we announced for gross revenue. And then those margins are 75%. Now, that changed a little bit from the last quarterly update. And that's because we're now, again, expanding operations in the United States and the practice group and insurance billings and sort of part of how the accounting works. But I'll turn to Essam if you want to add anything here as well.
Maybe just to add that the complexities of the US billing, as you mentioned, Bill, are that because of the way it works, that we are only recognizing as part of these financials what has come in this quarter. So the services might have been done this quarter, but we may not get paid until next quarter, for instance, or Q2 basically. And Q2, there might be some of those services done during that quarter that might not show up. So the advantage of it is, even though we've had organic growth from quarter to quarter, which is fantastic, especially when you talk about seasonality in medicine, that we can look forward to revenue that was not seen in this quarter, but provided services this quarter that might show up in hopefully will show up here in the next quarter here. So this is something that will be ongoing in terms of the leg of payment in the US. It's just usually, I think, maybe what, 45 to 60 days sometimes, Bill. I'm not sure exactly what the numbers are.
Yeah, sometimes it can take up to 90 days with health insurance across the United States. So, as Isam said, sometimes it takes a bit longer to get paid by those insurance companies, and the reflection of revenue is just what's hit the account as of today. And we're growing. So, this is just a graph that shows our quarterly financials, obviously growing quite quickly as you think about, where we are this year versus last year as well. And just to take it in a bit more depth across both of the countries that we're in. So looking at across Canada, looking at just pure patient volume, again, quite a lot of growth as you look at Q2 2025 until you get to Q1 of this year in terms of just the raw volume of patients across the country that we're seeing. We're very proud to say that that is continuing to grow organically across the country. And then south of the border in the United States, just as a high level, again, to frame for folks, I talked about it at the beginning regarding government funded health insurance. I always joke with my American friends that it took a Canadian to see the problem with Medicaid in the US healthcare system. It's really the closest thing to the Canadian single payer model. A federal mandate devolved to the states to build their own government funded payer. But of course, there's a lot of added complexity with you can see these Medicaid managed care plans and Medicare Advantage programs. And in addition to taking government funded health insurance, we do have a healthy payer mix where we're also into HR employer benefits, commercial, and then we take cash payments for some folks who would like to do it that way as well. And so you can see at the bottom, why it works and kind of that high level. And yeah, we're thrilled for the first time to announce our US patient growth. And this is stuff we've literally just announced as of the Q1 financials yesterday morning. So people may have been wondering like what's going on with all these payer contracts. And people have correctly said, okay, you win a contract, you're a network. That doesn't necessarily mean you're going to get patient volume. So in addition to all the stuff we showed you, we had to go out and build those marketing advertising funnels. We had to build patient recruitment systems. And we've successfully done so, growing exponentially month over month. And we did give a bit of guidance also in that Q1 about April. Looking forward, and you can see we've had quite a big growth from April over March as well in the total volume of completed visits across the United States. And so very excited about that and to show that we're actually making use of those in-network insurance contracts across the country. And, of those numbers, some of the patients that we're seeing are out of network. And there's a few reasons for that. We've highlighted a few of the main ones on this screen here for folks to be aware of. Obviously you heard about all of the AI technology, and so it's helpful to build patient volume as well there. But then, folks come in and of course we can retain them within our ecosystem because again, we're not just a virtual walk-in clinic. We have primary care, urgent care. We can keep folks coming back to us on a number of different visits. So maybe at a network today, won't be at a network in the future. Best to see them and bring them into the ecosystem rather than just sort of not see them at all. And then we can also take those patients that are coming in that are at a network and begin to file grievances with plans so that, we say to them, hey, look, we're at a network, but look at all your members that are coming to us. Obviously, access to care is not very good. You should sign a contract with us. And we've been, successfully leveraging that in some cases and, building future cases in that sense as well. And, generally just building up the whole ecosystem. So next, we're a marketplace, so supply demand. So I've showed you the demand side. On the supply side, thrilled with all of the doctors that are really flocking to the platform in the United States. And we really basically haven't spent any money on advertising to doctors. Many companies will go out, and I get pinged in my LinkedIn all the time, and maybe physicians on this call will have the same, where you get this sort of cold inbound of, hey, so Dr. So-and-so, will you come on to whatever? But we really, and I'll talk about it, have built this great system that doctors actually want to be part of to be truly independent again and practice as they like. And so what's interesting you'll note here is big boost in clinical hours, and then maybe not as much of a jump from March to April as it did from the patient volume, but that's because we have a lot of reserve capacity. And we discussed this as well in the release, but very exciting that, we've got almost 3 times the number of doctors currently working that are currently in credentialing. And, for context for folks, it can take upwards of 3 to 6 months to credential a physician. So you have to get them approved, even when you have a contract signed with the health insurance company. The insurance company then makes you submit all of the physician's licensing, documentation, et cetera, and then can take many months to actually say, okay, we agree with you. This is a real doctor. We're going to let them start to bill us now for the plan. So we got a ton of docs that have signed up that haven't even been able to start seeing patients yet. So very excited from that perspective as well. Um, and then just some, thoughts about our moat. I think we've talked about a number of those things over the last few slides, but again, 3.5 years basically of work going in to build that infrastructure that you saw, focusing on the government-funded health insurance, where many groups will simply say, well, we don't take it. We don't want to take Medicaid, or Medicare. Or, they might take it, but they do it, because they have to. They don't really want to, and the care is not really that great. Obviously the credentialing workflows, and then building the whole operation system around this, in addition to all of the other technology features that you heard, trying to build a better system to empower physicians to practice autonomously. And to that extent, very proud of the fact that we've built a web of physician leads across North America who work with us, and these folks are full-time practicing doctors from every territory that we're in, and pretty much every specialty, and come from a variety of institutions that you see on the right side of the screen, and also across Canada, and helping us to really expand the ability for doctors to feel comfortable joining us because they can talk to a peer who's in their geography and specialty, and then they help us build a better product and also tailor things to make sure that we're saying the right things and speaking the right language for clinicians. So I'm going to hand it back to
Yeah,
Isam.
you don't have to stop sharing. I can just talk through it. I think it's probably easier.
Okay.
Yeah, thanks, Bill. And maybe just to speak to the length of time for credentialing, Bill, that's something that hopefully with time will actually come down, where as we get the trust of the payers and so on, we'll be able to shrink that quite a bit. Correct? So
Yeah, you can eventually get delegated credentialing from the plans. So those are things that are options for the future.
we're working, yeah. So you're hearing a lot right now in the news about this company going IPOing and so on, and it's because we've been watching for the last few years here, but billions and billions and billions of dollars have been going into a lot of these new companies privately in different series, Series A and so on. Now they're at the stage of the cycle where they're starting to IPO. And first you have to get the big ones out of the way, and then you'll see the other ones come out. And what's interesting is some of these companies are younger than ours, but their valuations are incredible already, and just the nature of the way it works. Open Evidence, is a great company providing different solutions, as Bill mentioned, to doctors, and raised recently a $12 billion valuation. Health Navigator, years ago in 2019, Amazon was able to take them over and integrate them into their Amazon Care platform that they use right now. And then you have companies like Hippocratic AI that's created kind of AI nurses that they rent out or send to other. Can you go back? Sorry, Bill, and go back. They're providing these AI nurses for the different companies to rent and so on. But there's going to be a bunch of IPOs coming up. So watch for this space. It's going to be really interesting over the next little while. We have OpenAI, Anthropic, SpaceX, but you're going to see other ones too. I'm sure like the whole idea of spending all that money going into the private companies is for them to kind of eventually IPO. So the market will have a situation where these huge valuation companies, these unicorns, will IPO, and then the average investors are going to be looking for other solutions out there. So, speaking to those valuations, if you look at our valuation here on the next slide, you'll see that we're sitting at about a 50 million market cap, or 60 million market cap Canadian, versus, like we said before, the other ones. We're not comparable in the sense of the revenues and so on that they do, but that's not the point. The point is we're trying to create a sustainable solution, a sustainable model business plan that can grow and that hopefully has the legs to become a very profitable company in the future. And so we're working very diligently. We're very excited kind of about the growth already, the early success that we're seeing in the US, and it's something that kind of we're looking forward. So again, if you look at the next slide, I'm sure everybody here, if they're investors of the company, have looked at the stock price and watched it carefully. So, we've gone up, we've gone down, different natures based on whether there's warrants that had to be exercised that maybe brought it down a little bit. But at the end of the day, we're all shareholders too, and we're excited about the next stage in our company. I'm going to stop there and maybe we can stop sharing and see if there's any questions. So far, I'm only seeing one question. So if there's any other questions, feel free to kind of add them. So the first question was, how is May looking for completed US visits? So we don't give guidance, especially in a situation like this where if we can't give it to everybody, we can't talk about it. Our general idea, though, in terms of as a company, is to always keep growing organically. And there's always seasonality in medicine. That's just the nature of it. But even despite the seasonality, we want to see continued growth. And so this is something we kind of are proud of and something that we are trying to do. And eventually we'll be able to kind of announce the future numbers. Officially, Q2 will be announced by the end of August, I believe. Hopefully, between now and then, if there's other things that we can announce to the market, we will in press releases in terms of how the growth is going. And so we're looking forward to kind of give more information about our US growth and our Canadian growth along the way. Let's see if there's any more here. Any anecdotal feedback from doctors that have joined your platform in the US? So, Bill, can you speak to,
Yeah.
what doctors are saying about the platform?
Sure. And I actually, I'm licensed in California, New York, Maryland, and I've seen patients across in Ontario, Alberta, California, New York, Maryland myself. But generally, from physicians, the feedback has been quite positive that we've heard from folks. I don't believe a single doctor has left the platform in America since we launched. So that's obviously very reassuring. The proof of the pudding is in the eating, so to speak. But I think what we're hearing generally is that people are very pleased to be able to actually practice medicine the way that they want. So you're not under the thumb of corporate medicine. You're not told you got 15 minutes to pump out, a visit, and I don't care, what you need to do for them. That visit ends at the clock ticks, whatever. We say practice medicine the way you want. Organize yourself, order your labs, do your imaging. Here's the team that's built around you to support your practice. And I think that's resonating with doctors that are on the platform so far, from everything I can tell.
Great. Yeah, another question, what is your plan for expanding in the US? And I think we made reference to it on one of the slides talking about future expansions. Bill, you speak to this really well, where you mentioned how you picked initially California and New York and Maryland on purpose as being the most complicated ones and getting them out of the way. And then eventually a lot of them are a lot easier as we expand across the US and some of the next states that we're talking about.
Yeah, exactly. I mean, people often always, ask why, as you said, why did you pick those ones when they're so tough? But again, once you've cracked the California, New York nuts, everything else is a little bit more easy and straightforward. And of course, winning contracts with national insurance companies, they all have their kind of state branches, but it does make it somewhat more straightforward to do so and contract with them in other places once you've done in one. And as you can think about with Maryland, there are interstate licensing compacts. So there's, I think, 22 or 23 different states that Maryland participates with for interstate licensing. And there's a couple of big states like Florida, Texas, they look a lot like New York and California. So there's a lot of opportunity to basically grow. And now we have a playbook of how to do so successfully.
Yeah, so something to look forward to. Um, For the credentialing MDs, is there an estimate of how many patients they bring in versus how many you need to provide? So I think the question of doctors that already have practices coming on board versus doctors coming in for our marketplace. And I think most of the doctors coming in are for our marketplace, but there are some, especially in Canada, I think, that bring in their own hybrid practices.
Yeah, I'd say for the most part. And credentialing really refers to the US
Yeah.
because in
Yeah.
Canada, you don't really, we have the single payer that most docs are already in network with, so to speak. But yeah, most are coming on looking for us to help them build their practices, essentially.
Yeah. Okay, so let's see. What does the competitive landscape look like? Great question. I think we mentioned a few of those companies out there. They're not real true competitors in that space. I think me and Bill were on another call yesterday. We were struggling to figure out exactly an exact copy of what we do in another company, and I don't think there is an exact copy of what we do in another company. So there's a bunch of different companies providing different services. the traditional virtual care companies, and then you have the pure AI plays. And we're kind of a combination of various different ones and taking kind of the most sustainable, hopefully the best parts of them to create kind of the new version of the way healthcare is going to look and how healthcare is going to be delivered by the doctor who's now empowered to be their own boss. I think that's kind of very important. Again, if you're not limited to signing these big contracts and commuting an hour and a half to get to clinic and back and providing 24/7 care and not having any coverage when you want to take vacation, it opens up a lot of hours from doctors that can spend 2 hours here, 4 hours there, 6 hours there, that historically they were hesitant to do. And so there's a lot of capacity to grow there. Um, what is the expected number of visits each physician will have capacity for versus forecast expectation? I think it depends again on whether they're in Canada versus US and how much time they have to spend to bill, the payers and so on. Bill, you speak to that sometimes where in the US they're spending about 15, 20 minutes, I believe, per patient.
Yeah, I'll say that we've done some various analytics, at least across Canada, and have found the average doctor does about 7 hours a week on the platform, roughly or so, is kind of how we think about it. But of course, some are practicing full time essentially, some are doing part time. Like that's the thing, and some change that volume on a week to week or month to month basis because again, it's entirely flexible on the physician's schedule and they can kind of do as they please. But of course, what we kind of think about is just looking at those numbers of patient volumes going up and empty hours otherwise.
So I got a great question here that we're in the first inning of adoption. I'm a big baseball fan, so I agree. I don't even know if we're in the first inning even. It's very early in the process in terms of adoption in the US. How does the thinking about ability to scale up the doctors and patients signing up to the platform? I mean, we are looking at different ways to do that. We have some great teams that are helping right now. In terms of what Bill mentioned, we already have a pipeline of doctors onboarded that are waiting for credentialing. We haven't really spent any resources attracting them. If we need to in the future, there are ways of doing that. But up to this point, it's the other way around that we're focusing on the patients coming onto the platform. But we have plans to do that in each jurisdiction as we expand. How often we'll be doing town halls? Good question. I'm hoping that we can do it at least quarterly. I think it's a good way to kind of summarize for new investors and old investors and so on, kind of where we are, where we're going. I think eventually we'll have more and more to talk about and more to present. So I think this is a good platform to present that. And we're recording it, so hopefully we'll be able to have it on our website for future reference as well if someone missed the meeting today. I can't speak to any guidance, so any questions about guidance and so on, we can't speak to it here. Are you able to estimate patient churn? I mean, we have historical data in Canada, I believe. Bill, maybe you can speak to that.
Yeah, well, I sort of would reframe a little bit because unlike, again, those traditional kind of virtual walk-in clinics or like membership sales platforms that folks may be familiar with, where they have very low utilization and then people cancel their memberships, like we don't really work that way where it's that 5% of people utilize or whatever. It's people come onto the platform and then are put into our system where it's a mixture of primary care and urgent care. And so, really, what they're getting is a doctor for life. So, what we have done is a cohort analyses where we've followed patients out over many years and have found almost everybody comes back for a second visit over the course of a couple of years. Many people will use this 12 to 13 times, people with chronic illness and otherwise. And so again, they realize like, hey, I can actually use Rocket Doctor or physicians on Rocket Doctor for everything. So those are kind of the main metrics that we track in terms of like the cohort analyses and retention rate in that sense, rather than churn rate.
Great. I think that's it for the questions we can answer. I hope we've been able to show kind of the excitement that we have and how proud we are of the team to get it to this point. And kind of the next stage and next quarters that are going to be coming out. Hopefully, you guys will be part of it as well. And if there's any further questions, I think if you continue to type them, we might be able to get to them in the future. But as of now, I'm probably going to go ahead and conclude this town hall. Thank you for everybody.
Thanks, everyone.